presenting problems in HIV. So we have lymphadenopathy. It could be either due to TB or lymphoma. In case of TB, we can do needle aspiration, and in lymphoma, we do excision biopsy. This is a picture of an enlarged lymph node. And weight loss, there is more loss of more than 10% of body weight. It can be due to unexplained diarrhea for over a month. Then we have fever of unknown origin, where the fever lasts for more than 1 month, and despite all the routine and special investigations, we are not able to identify the cause of fever is unknown. It remains unknown. Now, if the patient is consulting the doctor for as an OP patient for around 4 weeks, and we're not able to come to a conclusion or a cause of the fever, or if the patient is admitted, let's say a patient is admitted with high fever for around 3 days, and still and despite running all the tests possible, we're not able to come to a conclusion as to what is causing this fever, then that is called pyrexia of unknown origin, fever of unknown origin. Then we have mucocutaneous diseases. So they are divided into scaly rashes, pruritic, non-pruritic, and blisters. In scaly rashes, we have psoriasis, tinea corporis, and scabies. Scabies, which also comes under pruritic. And then in non-pruritic, we have Kaposi sarcoma. So this Kaposi sarcoma is a cancer of the endothelial origin. It is most common in patients who are HIV positive, who are highly immunocompromised patients, like patients who are on transplant and on corticosteroid, long-term corticosteroid therapy. Molluscum contagiosum, then warts. In blisters, we have the herpes simplex, and herpes zoster, and drug rashes. There are several drugs. There are several drugs which can cause blisters. Even lamivudine has a very common side effect of causing rashes. Now, if this blistering is over more than 30% of the body surface area, then it is called as toxic epidermonecrolytic syndrome, which we will look later. Then we have seborrheic dermatitis. So the most common regions where it appears is near the nasolabial fold and hairy areas. So treatment, we can give antifungal and selenium sulfide shampoo if in case there is scalp involvement. And in herpes, we have simplex and the zoster. Now simplex, we see it more common in the nasolabial and the anogenital ulcers. And if these lesions or if these ulcers they last for over 4 weeks, then that's when we call them as AIDS defining disease. And the treatment, as a viral infection, we can give acyclovir 400 mg twice a day for 6 months. This is a picture. Now in herpes zoster, it is dermatomal. The distribution would be dermatomal, which is very classic of zoster. It is because of reactivation of the virus, and it is mostly unilateral, whereas simplex can be unilateral or bilateral. And there is increased risk of post-herpetic neuralgia, which is said to be relieved sometimes by application of something called topical capsaicin, which inhibits substance P and therefore reduces pain. We can also give acyclovir and pregabalin. This is a classic example. We can see the dermatomal distribution of these lesions, unilateral distribution of lesion. Then we have Kaposi sarcoma. So it is caused by human herpes virus 8. Human herpes virus 8. It is a rare cancer of endothelial origin. Now there are around 4 types, but in Davidson there is classical, endemic, and AIDS associated. They are purplish brown plaques or nodules, which are often on the face or lower extremities. They are present in the lower extremities, and here we have like red patches in the face, in your nose. They classically appear when the CD4 cell count is around 400 cells per microliter. Then we have drug rashes. So the most common drug that causes rashes are sulfonamides, as we all know, but then NNRTIs can also cause blistering. As I already explained earlier, if these blisters are present in more than 30% of body surface area, then they are called as it is called as toxic epidermal necrolysis. So this is how it looks. We can see a lot of blistering, and you can see the fluid collection under. This is a drug induced skin reaction. Now, if the same reaction occurs, but it occurs with mucocutaneous involvement, your mucosa is also involved, and there is also cutaneous involvement, that's when we call it as Stevens-Johnson syndrome. Then we come to oral diseases. So the most common manifestation as an opportunistic infection would be oral thrush, oral candidiasis, which is caused due to, as we all know, Candida albicans. Then we have hairy leukoplakia. We can see in the lateral side of the tongue, we can see these hairy white corrugations. Then this is erythematous candidiasis. As the word says, erythema, there is glossy red tongue. Then pseudomembranous candidiasis. Here, there's a membrane formation. You can see the difference. Then we have gingivitis and the periodontal diseases. Then we have oral warts. Then we have esophageal disease, the most common being esophageal candidiasis, and it can be diagnosed with the help of an esophagoscopy. And if it lasts for more than a month, then it's called as an AIDS-defining condition. For treatment, we can give fluconazole 200 mg for 14 days. Then diarrhea, which is a very common manifestation and present in almost all the HIV patients. And now we can divide based on small bowel and large bowel. Now, in small bowel diarrhea and large bowel diarrhea, the urgency would be there in large bowel. The straining would be more in large bowel, and the frequency is increased. The volume would be normal, and mucus is present. Blood here will be fresh. If in case blood is present, here it will be fresh. Whereas in small bowel diarrhea, if it is present, it will be black. Then that's when it's called melena. Why is this so? Because when it is now because when a pathogen has invaded the small bowel, now it has the and if there is some blood that is here, it has to pass through the large intestine and then come out via the rectum. So by the time it takes this long route, by that time the blood would become all dried and black. Whereas in large bowel diarrhea, it has to only pass through the rectum. So therefore the blood, if present, it will be fresh. And weight loss is usually absent. Vomiting can be present. Appetite is normal in most of the cases. So, organisms which cause small bowel diarrhea and large bowel diarrhea: cryptosporidiasis, microsporidiasis, isosporiasis, and large bowel diarrhea. We have Campylobacter, Shigella, Salmonella, and Clostridium difficile. So, this is a picture of a diagnostic duodenal biopsy, and for treatment, we can give nitrous oxide, albendazole, or ciprofloxacin. Now we have Mycobacterium avium complex. Here the causative organism is non-tuberculous mycobacteria, most common being Mycobacterium avium or Mycobacterium intracellularare. Now this can cause lymphadenopathy, hepatosplenomegaly. There are different types of MAC. It is basically like the less known cousin of TB, but then it is different from TB. It's not TB. And this is a picture, this is an image where it disseminates. Basically the mycobacteria, it disseminates and affects your bone, the liver, the spleen. And then here there's a picture of a chest x-ray where we can see bilateral lobar consolidation, and there are reticular and interstitial infiltrates. The most common type of MAC is pulmonary MAC. This is an example of a pulmonary MAC. So biopsy is done often, which shows granulomas and consists of acid fast bacilli. Acid fast bacilli and granulomas. Now for drugs, a good mnemonic would be just MAC itself, MACR. Now MAC, M for MAC drugs: azithromycin, clarithromycin, rifabutin, and ethambutol. Then we come to respiratory diseases. So the most important and common would be pneumocystitis jirovecii pneumonia. Now this manifests if the CD4 count drops to less than 200 cells per microliter, and if there is progressive dyspnea for less than 12 weeks. Now what are the clinical features, the presenting symptoms? Retrosternal chest pain which increases on inspiration, hypoxia on exertion. Now that's why diagnostically we do a 6-minute walk test. For chest x-ray, here we can see interstitial infiltrates, that too, which are spreading from the hilum. This is the hilum, this is the hilum region. It's spreading from the hilum, but we can see that these interstitial infiltrates, they're not present in the peripheral region, and so are they absent in the basal region as well. So therefore there is bilateral interstitial infiltrates that spread from the hilar region, and basal and peripheral sparing is seen. So this is the peripheral region where you don't see any infiltrates. Check here. And then even in the basal region there are no infiltrations. Then for treatment, we give trimethoprim sulfamethoxazole 200 mg per kg for around 3 weeks. Then pulmonary TB is when CD4 count manifests when CD4 count drops to around 300 cells per microliter. In chest X-ray, we can see an evident hilar and or mediastinal lymphadenopathy. Then treatment would be anti-TB regimen first. Then around 2 to 8 weeks later, we start antiretroviral therapy. Now, why do we give this gap? This gap is definitely very necessary, because in some cases, now why do we give anti-TB drugs? Why do we give ART? We give these in hope to improve the symptoms so that the disease resides. But then sometimes what happens is that there occurs a phenomenon called as so the IRIS means immune reconstitution inflammatory syndrome. So this is a condition where when we give all medications in hope to improve the symptoms and to improve the course of the disease, there's a paradoxical worsening. Now, why does this happen? In case of HIV, when the body is completely immunocompromised, that is, our immune system lacks, throughout the course of the disease, the immune system becomes so incompetent that it lacks the ability to even to identify any cell that causes danger to our body. So at a point when we give drugs which activate our immune system, that is when we give antiretroviral therapy which will kill the virus and tries to activate or tries to improve our immune system, then our immune system, which had its eyes kept closed the entire time, now will open its eyes, and now it'll it'll seem like as though all those cells which are attacking our body, which were hiding from our immune system, are now being recognized by our immune system itself. So that is why there's a paradoxical worsening, because of the heightened inflammation that is launched against these cells. So and because of iris, even iris can even cause uveitis. And then we have bacterial pneumonia. So bacterial pneumonia, the it usually manifests when CD4 count is less than 300 cells per microliter. Then we have PMLE, progressive multifocal leukoencephalopathy. This is because of reactivation of the latent JC virus, the John Cunningham virus, in white matter, and it is a demyelinating disease. Clinical features, as we can see, would be somewhat similar to our stroke: weakness, paralysis, vision and speech problems, slurred speech. Then diagnosis, we can do lumbar puncture, PCR testing, a brain MRI. Now, these are the pictures of a brain MRI. Here we can see lesions in the white matter, as you can see here, and lesions in the white matter. Sorry, we can see lesions in white matter. So treatment would be ART, and we can stop immunosuppressants. If we can afford to stop immunosuppressants, then yes. Then we have cerebral toxoplasmosis. Here, the residual Toxoplasma gondii cysts become reactivated, and this manifests CD4 count less than 100 cells per microliter. Here, we can see classical ring enhancement lesions, and edema will be present. Treatment would be sulfadixim plus pyrimethamine along with folinic acid. Then we have CMV encephalitis, CD4 count less than 50 cells per microliter. We can give janicyclovir 5 mg per kg. CNS lymphoma at CD4 less than 100 cells per microliter. Then cryptococcal meningitis, it is most commonly caused by the cryptococcal neoformans, and CD4 less than 100 cells per microliter. That is when this manifests. It can be diagnosed by carrying out a simple cryptococcal antigen test. For treatment, we can give amphotericin B for 2 weeks and fluconazole. Now, the normal intracranial pressure is less than 20 centimeter H2O. Now, if there is any sort of increase over this range, then that is when we say that there is increase in ICP, then we do a lumbar puncture to relieve the pressure. Here we can see these lesions. Here you go. Then we have CMV retinitis, which is the worst stage, the worst opportunistic infection ever, because like the lesser the cell count, the CD4 cell count drops, the more we'll have neurological manifestations, and the more will be the brain involvement. If a person who's HIV positive has CMV retinitis, that probably means that he's towards the end of the disease course. And then there's pizza pie appearance in CMV retinitis. So this is an image of fundoscopy. And why do we say that this is a pizza pie appearance? Is because now here we can see these whitish infiltrates. Now these are nothing but the necrotized infiltrates, the dead matter. And then here we have red spots. Red spots. Here and there we have red spots. These red spots are they are hemorrhages. Now if we actually look, this looks like a cut pizza, a pizza slice, and these red spots look like ketchup, so that's why it's called pizza pie appearance of fundus. Scotoma would be present, photopsia is present. We can diagnose with the help of a PCR. And then for treatment, if in case this is usually a medical emergency, so most of the times when it is a medical emergency, we can right away give valganciclovir subcutaneously. But if it's not an emergency, then we can administer oral valganciclovir, which is OS. Thank you.